Seems virtual shadowing. Today we have Dr. Raymond Fowler. He's the director of the pre-health virtual shadowing program. I think most of y'all know that already. And he's a professor in emergency medicine. I hope y'all enjoy today's session.
All right, I'll start my slides. Sneha, can we see that all right? We're good? All right. Well, good evening, everybody. I'm glad you could make it. My name is Ray Fowler. I'm an emergency doc. I have been practicing medicine 43 years. I'm at the University of Texas Southwestern Medical Center in Dallas, Texas, where I am professor of emergency medicine and emergency medical services. And I'm chief of the division of EMS for UT Southwestern, which is a somewhat new division for us. We actually have a division in the university dedicated to pre-hospital care, if you can imagine that. Our affiliated division, that of global health and disaster medicine, is also a division because we recognize that we have enormous responsibilities for people that are outside the hospital. Needless to say, with our ice storm a couple of weeks ago here, we realized that the hard way, but certainly with a pandemic that's now killed 520,000 Americans in a mere 1 year, we certainly recognize the fact that people, wherever they are entitled to live their lives with respect and dignity. Tonight, we're going to talk about that. I'm going to talk about several things. One is how I got here, and secondly, what I do, and then thirdly, what we're doing online with our virtual shadowing program. And then the last thing I'm going to talk about, which will be in about 40 minutes, will be Fowler's 15 laws of safe emergency medicine practice. And I want you to take notes on that, and I'll make my slides available to you. 15 tips that I've seen along the way about how physicians really mess up and hurt people. And if you are really taking the vow and the oath of medicine going forward, you don't want to hurt anybody, right? Let's get started. There's a wonderful book that I just read for the third time called Hiroshima by John Hersey. You know what happened on August the 6th, 1945 at 8:15 in the morning in Hiroshima, Japan. The sun appeared about 1,800 feet above the ground, causing an explosion that killed 100,000 people instantly, wounding and burning another 100,000 that died over the space of the next few weeks. Hersey talks a great deal about what happened that day, and it's a horrifying thing to read. He's a very good writer. I encourage you to read, and I encourage you to read good writers. You know, a good writer can write about anything. He can write about cotton bowls, and still you go, whoa, this is a great book. This is a terrific book about the horrible thing that happened that day. And then Hersey goes on over the next 40 years and follows 6 people who were there when the bomb went off that day. One of whom was a family medicine doctor, Dr. Okada, I believe was his name. And Dr. Okada had done very well. He'd made a lot of money. And then the explosion happened, which wiped him out financially. And then over the space of the next 20 or so years, he rebuilt his practice slowly. You know, they needed doctors there. And he became very successful. He became wealthy, really enjoyed life, loved having a good dinner and a drink and so on. And he went to Tokyo in the late 60s, maybe early 70s, about 20, 25 years later, to visit some friends. And they said, hey, you know, since you're here, we have one of these new scanners. Why don't we just do a complete physical on you and see how you're coming along? And so they did, and they found this mass on his left lung. And they said, well, it could be cancer because of your exposure to the atomic bomb. So we should operate and take this thing out. And they did, and it was cancer. And they got it out, but post-operatively, one of the stitches internally came off and he began to bleed to death. And it was awful. And he was slipping away. He was about to die. And then because of the blood pressure became so low, the bleeding stopped. And ultimately, finally, he began to recover. But he was in terrible shape. He felt horrible. He was physically felt awful. And he really just honestly gave up. Here was a doctor giving up. And he was just there in his room, frail and, you know, hopeless. And one of his family came in and they said, you know, there's an oath that you physicians in Japan take. And that oath is that medicine is the art of compassion. And you as a doctor, why can you not be compassionate with yourself? And Dr. Arquette thought about that. And he realized the fact that he had to be kind to himself and as well. So he began to put himself on the path to recovery, ultimately did recover and was able to go back practicing medicine and lived a long time. I bring that up because it took me reading that book for the third time to see that line. And really, even though I'd been a physician for years, as I read the book the first time, the second time, I didn't see that line. And now, having been on the admissions committee at UT Southwestern Medical School for 9 years and working with admissions for about 13 years, we've had during that time about 60,000 applications to our medical school. This past year alone, we interviewed 771 pre-med students for the med school. And I realized we've interviewed all these thousands of people during the time I've been on the committee. And I honestly hadn't thought about the fact that, are we really asking people, why do you want to become a doctor? Because medicine is, ladies and gentlemen, the art of compassion. And the only reason to get into this field is because you honestly, legitimately, personally have a deep sense of feeling for other people. Absent that, nothing else lasts, folks. And so in medicine, what we are doing is that we are using two things, really. We are taking an applied science that we learn and we dedicate it to the human condition. It has to be both. If there is a mistake that I see as an old man, I'll be 69 this year. I've been in medicine almost a half century. I've been practicing 43 years. It'll be 44 years come summer. It is that I see so many people who are caring for people who obviously really don't love caring for people, because patients, especially in my world, in the emergency department, people don't come to see me because they're having a nice day. I guess you can imagine that. They're in pain, they're afraid, they're nauseated, vomiting, diarrhea, dehydrated, they've been injured, they're bleeding, they're having chest pain, they're short of breath, or abdominal pain, or appendicitis, or a ruptured organ of some sort. But they are terrified. And it is both my job, ladies and gentlemen, and my oath to be compassionate to them. I ask you tonight to put this in the back of your mind, or as Glenn Oliver Dempsey, who was a physics teacher for me in high school, his initials, Glenn Oliver Dempsey was his name. His initials were God. It's true. And he used to say, put it on the third brain cell on the left up here. So I want you to put it on your third brain cell on the left and say, do I really have that compassion for others? H. Newen said, compassion asks us to go where it hurts, to enter into the places of pain, to share in brokenness and fear and confusion and anguish. Compassion challenges us to cry out with those that are in misery, to mourn with those who are lonely, to weep with those who are in tears. Compassion means full immersion into the condition of being human. So let me tell you where I came from. I'm a native of Western Georgia. I just got back a couple of days ago from my home. I grew up west of Atlanta, about a half an hour. The land I keep my house in Georgia. I live in an apartment here in Dallas, Texas, where I'm working. And the land I live on, my grandfather bought over a century ago. So I'm a native Western Georgian, and I have deep, deep roots there. I went to the university with the best football team in the world, University of Georgia. That's a joke. And I went on to the Medical College of Georgia. I briefly went into surgery, decided I just didn't like it. And so I moved in 1978 to working emergency medicine full-time in Augusta, Georgia. And then 2 years later, I went home to practice emergency medicine for 20 years in my hometown. I retired in 2000 with the millennium. And a friend of mine who had taken over Parkland Hospital ER hired me 20 years ago last month to come and be a part and to become an academic, to change careers. While I was in Georgia, I managed emergency departments. I was a business guy. I built an urgent care center in my hometown and ran that for 20 years. I was hometown boy come home. You know, my dad was from there. My granddad was from there. So it was nice for many people to see a hometown boy that they knew to come home and be a hometown doc. And I did that. I established deep roots in my community for a generation. I also set up a billing company. And then along the way, I wandered into the issues of things that I was really interested in. In 1984 and then 1985, for example, we founded the first national emergency medical services physician organization, which is still going today, the National Association of EMS Physicians, which has actually become the subspecialty organization for EMS medicine. You say, wait a minute, I thought EMS was paramedics. There is a board certified specialty of EMS medicine, emergency medical services medicine. I was initially self-taught, and all of us were in EMS in those days, but now EMS medicine is a formal training program, and we train that here as faculty here at UT Southwestern. Now, one of the first points I want to make for you, and let me grab my clock to make sure I keep my eye on the clock here, is this. It may be that you are able to plan your life and that you've already done that. It was said that the only person who ever planned every minute of his life was Dwight David Eisenhower, past president of the United States, five-star general. He led the assault on D-Day and so forth. But most of us don't do that. Most of us react to things like opportunity. We come across roads that are divided and we go this way, or we go that way. We go to the road traveled more, or the road with Robert Frost that was less traveled. One of my heroes, who he's passed away now, was Stephen Jay Gould. Stephen Jay Gould was a magnificent individual. He was a Harvard geologist, a genius, and he was an evolutionist. I don't know how much you read about evolutionary theory. And he wrote extensively in Natural History magazine, elegant articles every month for years. And he assembled those articles into books. And he has a wide population of books that he wrote over the years. I have many of them. And he was a great speaker. I actually got on an airplane in Atlanta one time and flew to College Station, Texas, to hear him talk about punctuated equilibrium, which was a new theory in how evolution seemed to have made its way around the earth. And Stephen Jay Gould was a very interesting guy, and as I said, a magnificent writer and a wonderful speaker. He said this, now this is coming from an evolutionist. He said, the tape of life, if rewound, would not play the same way a second time. Now, what on earth does that mean? He said, think about it, that you don't see it anymore, videotape and cassette tape. You smile at those things, but that's what we had back when he was around. And that if you took the tape and rewound it, you would think the movie would play exactly the same way. And he said, it's not that way at all. And folks, this is exactly what has happened in my life, as now in the latter part, the autumn of my life, as an academic now, but starting a career in business, is that my life has been one of so many changes, so many roads where I had to make a decision to go left or to go right. And the things that happened to me, the relationships, my friends, the people that I know, the mistakes that I made, the stupid things I did in business, the money I wasted, and how so very careful I am today and how ignorant I was. I hope that maybe you feel confident that you're planning your life out. But I suspect that you can't plan too terribly far ahead and focus here. That's perfectly okay. It is perfectly okay that there will be a lot of indecision in your life, and a lot of things happen to you that take you down different sides or different paths. And that is perfectly okay. Because if you work hard, that is, have a great work ethic, and if you have some reasonable smarts, which means some aptitude, good work ethic, some reasonable smarts, you're going to be fine. I'll give you a list of stupid things not to do in just a moment. And so as we think about the tape of life being rewound, why then go into medicine? Your journey to medical school or PA school or nursing school or as a technician or wherever your path is starts first with, do you have compassion? Do you have a real interest in the lives of others? You must reflect on that. Think about this. Take some personal time. Turn your damn smartphone off and quit distracting yourself and think about what makes you happy. And if joy in the lives of others and feeling a sense of wanting to be of assistance and engaged in the lives of others, that is a test of compassion. The second thing is what I mentioned a moment ago is work ethic. Folks, the path to medicine is hard. We're going to talk about that some more in just a minute. You have to have a strong work ethic, which means also you have to be committed. You can't just half do this. This requires a commitment. Medicine won't just happen to you. You're going to have to slave away day after day for years. It's going to be college, it's going to be medical school, it's going to be residency, possibly a fellowship, and then you have to find a job at the age of 29, 30, or 31, being $200,000 or $300,000 in debt. And it's going to take commitment to get there and to later find the job and pay that debt off. And then, of course, is the issue of science. Medicine is applied science. And I will tell you one thing. I have been involved. I got into medicine in 1973, 48 years ago. And I will tell you that medicine has changed so much, and it requires continuous study. Let me give you one example. We had a year ago a brand new disease in America that has now killed 530,000 Americans, a brand new disease. And up to and including my reading today in the Journal of the American Medical Association and the New England Journal of Medicine, both of which I was reading today, about prospective treatments for COVID. It's a continual study. So much information has emerged about this massive coronavirus onslaught onto humans of stuff that we just didn't know. Why is it causing the problems? Why does it kill people? Why does it cause this terrible, unrelenting pneumonia, respiratory failure, and so forth, that once people get on a ventilator, they may not survive? And that the routine pathway that we would take for a guy with severe emphysema with an exacerbation of chronic obstructive pulmonary disease and jam a tube down his throat, put him to sleep, stick him asleep, put him on a ventilator, and that he will get better a little later, didn't work with COVID, a brand new disease. You have to study constantly. Folks, don't go into medicine unless you plan to be studying all the time. Here is Fowler's tip to you. I challenge you. Look up everything you don't know. Sorry, I'm talking so loud. Look up everything you don't know. You do that, you'll be fine. But it will take that to have a successful path in medicine. Now, I want to move into something that may be a little bit sensitive, but I'm going to say it anyway. You must act like the professional that you are asking the admissions committee to believe that you are or will be. Because after all, if you think about it for a moment, you will be applying to medical school or and a bit less so to PA school or NP school. But to med school, you're applying for a $6 million job. You think I'm kidding? $200,000 a year times 30 years is $6 million. $300,000 a year, which is about typical salary for a full-time employed emergency doc, times 20 years is $6 million. So my question to you is, let us say for a moment that you were running the hiring for a company and you were interviewing candidates for a $6 million job, and you're in charge of the hiring. How picky would you be? You think you would pick the best of the best? Well, let me tell you something. It's interesting being on the side of where, as part of the admissions committee and being part of the university, where we bring these kids here. Kid is a compliment, by the way. I am an old guy. You're a kid, then that's a compliment. your life will go by very fast. You will be amazed how quickly. I know you hear old guys say that, but your life will go by so quickly. In the med school, once we hire these kids and bring them in, we study them and say, are there predictors that the med students would get in trouble later? You say, what do you mean trouble? Once you get a degree as a physician and finish your residency, you then have to get yourself certified wherever state you're in with the medical board for the state. And a study was done here a couple of years ago looking at predictors. Were there any predictors of the med students' behavior that they would actually later, in some sort of related behavior, get themselves in trouble and in fact sanctioned by the medical board and in fact have their licenses jerked? Well, there are. It turns out that being late to work was a predictor, that the students being late to work as while on the rotations at the medical school was a predictor that later they'd get in trouble with the medical board. And also failure to complete projects, including completing them on time. Isn't that interesting? That being tardy and being incomplete was a predictor later of offense. Offenses like what? Drinking, doing drugs, writing prescriptions for yourself, writing narcotics for the family, inappropriate behavior in an exam room, fraudulently billing Medicare and Medicaid. All these things could be predicted by the behavior of the medical students. My old dad said, my dad was a great man. He flew B-17 bombers in World War II. He flew bombers over Austria. He was based in Italy. He was a bad dude, and he was an Army general. And he said, and so he ran his family kind of like an army, do what I say, son. He said some things that were quite wise. And he said this, he said, people tell you all about themselves that you ever want to know. You just have to pay attention. That applies to you also. So if someone were to observe you externally, what would they learn about you? Look in the mirror, not now, but later, along the way, and be honest with yourself. And so on the admissions committee then, we want to find out about you. Now, this is a take-home point. Please focus and read what's in the box. Can you demonstrate now or upcoming convincingly why you want to become a doctor? Or let's emphasize why you want to become a doctor. Can you explain that? Because you're going to have to. Somebody on the admissions committee is going to look at you and say, why do you want to do this? And folks, it starts with compassion, the work ethic, and having some aptitude committed to compassion, to the betterment of the human condition. Focus. You have to be able to state that, and that is true. And your essays have to say that. That is true. So how do you demonstrate your commitment? Great points, folks. This year on the admissions committee, we did not really hardly look at many MCATs under 515. Some of you may not have taken the MCAT yet, but you know that 528 is a perfect score. 515 is an A. We didn't look at a lot of people, nearly 800 people that we interviewed, much under 515s, very, very competitive. Moreover, ladies and gentlemen, our applicants to med school in this COVID year with our virtual interviews were up 30% this year. Did you hear what I said? The competition went up 30% this year, the applicants to our med school. Holy cow. And so your MCAT scores are going to be exceptionally important. It has been my considered experience having interviewed, I have presented to the committee probably 500 candidates myself. We have to take the candidates. We do about 80 at a time. We divide them up, and we will each present 5, 6, 7 for the evening in our 4-hour meetings that we have. It has been my general observation that people tend to do on the MCAT kind of sort of the same score range that they did on the SAT and the ACT. So focus point, go back and look at your SAT and see how you did. And so if you made a 1200 of 1600, that's pretty good, but that's about a 508 out of a 528 or 510, maybe 508. Let's keep moving because we're going to run out of time. We look at shadowing activities. This is why we started the virtual shadowing website. And I really, Sneha, I want to really commend you for what a great service this is that you're doing here. We look at community service. We look at social awareness. We look at the demonstration of teamwork. For example, were you on a football team or a soccer team or a hockey team or a swimming team? We very much we read every word of your letters of reference. So pick your folks that are going to write your letters very carefully. And folks, we absolutely pay attention to your interviews. We look you straight in the eye. We want to know why you want to become a doctor. We want you to be able to explain some of your activities. We want you to be able to, if you've done some research, what have you be able to explain it? Exactly what did you do? If you wrote a paper, we will have read about it. And can you tell us about the paper that you wrote so that you can demonstrate that you really are who you are? Now, this is going to be sensitive. I don't mean to offend anybody, but this is just honest. This is my direct observation from my medical school admissions committee experience. Folks, if you're going to try to get in med school, don't do anything stupid. The things that will likely make sure that you will not get in med school, if you get a DUI, folks, chances are you're not going to get in med school. It'll be impossible to explain. And you probably won't get an interview. You may get an interview, but if your school prohibits on-campus alcohol, don't have a freaking beer can in your dorm room. Don't do it, because then you'll have to explain it. Well, there was a party in my room and somebody brought beer and I didn't know it was there. And I know the beer can in my trash can, and I'm terribly sorry. And I know I was disciplined for that. And I've learned my lesson, and I do not have a problem with alcohol. Do you really want to be explaining to that when you are interviewing for a $6 million job? Really? Do you really want to have to do that? Just don't do it. Getting arrested for abusive or violent behavior like drunk and disorderly, don't do it. You've got to live the life that you're going to be. So really, it's anything that you end up having to write an explanation for that includes, well, since then, I have learned that actions matter, and I will be much more careful in the future. Folks, I know I sound like old grandpa, and if this kind of makes you mad, I'm sorry, I don't mean to, but wouldn't it be a darn shame to work so hard and to put in all that time to make the grades that you're making, and to end up with a beer can in the trash can in a dorm room, and that gets you dinked, and maybe your admissions application won't get looked at. All right, moving on. The med school experience, folks, getting in med school is just stepping up on the first step. It is a lot of work. You're just getting started. And folks, in med school, you've got to make straight A's. You've got to make great grades. Why? Because at the end of med school, or toward the end, you've got to get into a residency program. Med school alone doesn't give you a job. You can't even practice medicine. You have to, after 4 years of medical school, you have to then go get further training in some specialty like surgery, internal medicine, emergency medicine, ENT, and so forth. And so you've got to make great grades to get into a residency. You have to do well on your STEP exams. I realize that step 1 is pass fail. I get that. But I'm telling you that with certain parts of it being pass fail, it's going to make the competition in other areas, for example, how you do on your rotations, much more important. And then you have to let me start the sentence over. Then you have to figure out what you want to do with your life. Do you want to go home and do family medicine? That's a wonderful career. I did 20 years at home in my urgent care center of a lot of family medicine. I held the hands of many people whose wives have died, and they came into my office and sat on the couch and just cried. And the connection that you get with as a community is marvelous. Or surgery, or ENT, or you name it. But you've got to figure out what you want to do. And chances are most people probably don't know when they get into medical school what they want their career to be. But the sum of all this about the med school experience is that you will be applying for a residency before you know it. And then after 3 or 4 or 5 years of a residency, or if you do neurosurgery, it could be 5, 6, or 7 years. Then you have to hunt for a job. And in my world of emergency medicine, we tie for the largest residency in emergency medicine in the nation. here at Parkland Hospital at UT Southwestern. And we have 22 residents per year. And so we have residents that are about to graduate in July. And I'll tell you, the job market is tight. You may have to, many of these residents about to graduate may have to go out to the more rural area, uproot themselves from Dallas and go out to West Texas somewhere where they can definitely find a job. But at the end of near the end of your residency, you'll have to be hunting for a job. So the whole thing, folks, ain't made in the shade once you get into medical school. Now, what about taking a gap year? I have to say that in the last 4 or 5 years on the admissions committee, that is becoming very common. And so I would say go for it. But listen, if you are going to take a year off after college, and that's fine, you have to be taking that year off to do something. For example, start a master's program. Let me strongly suggest that you take some, it's called post-bac, which is post-baccalaureate. Baccalaureate is your graduate from college. Post-bac coursework. I like to see people staying in school and continuing to take a course along the way and making straight A's while you're doing that. But if you want to go to Spain and learn Spanish, that's fine. If you want to go to Japan and learn Japanese during that year, that's fine. If you want to do research, wonderful. Reagan Rosenberger, who I introduced, I forget, Reagan helped me write this talk. She was at the beginning slide. Reagan is one of the chiefs with me on this virtual shadowing program. She's taken a gap year and a full-time research assistant in the division of EMS here at UT Southwestern. So take a gap year, sure, but make sure you have a plan for what you're going to be doing during the gap year. Very quickly about emergency medicine. I love this field. I kind of backed into it. It was a Stephen Jay Gould moment. And I found myself blinking my eyes and 20 years passed. Emergency medicine is the emergency aspects of all conditions, all ages, all genders, all ethnicities, all languages, of all diseases at all hours of day, 7 days a week. And it is a field of continuous study. ERs, of course, run 24 hours a day, 7 days a week. We typically work 8 to 12-hour shifts. The first year I started out in 78, we worked 24 on and 48 off. That was miserable. And after that, we changed to 12 on and 12 off, and that seemed like a holiday. Emergency medicine is a great career. It's well paid. It's hard work. It is a high liability situation. And you have to be right. And I'll talk to you about my 15 laws of emergency medicine in a moment. Now, one of the things that we look at for candidates to medical school is, do we think that there are possibly people who might burn out? This is part of the shadowing experience. We want folks to shadow so that they know what they're getting into. Have you ever even been around a doctor before? This is why shadowing is so important. And I know COVID has shut down much of the shadowing experience. That's why we started the virtual shadowing website, which I'll tell you about in a moment, 9 months ago. And so that people could get some shadowing experience. But what is burnout? A friend of mine said that burnout is the response of a normal person to a toxic environment. And really, what I see in people that quote unquote burn out is that people get tired of taking care of sick people and they stop being interested in their job. And what I'm afraid of with burnout is that they lose the art of compassion, because the art of compassion, ladies and gentlemen, is at the heart of this. Or maybe they never really had it. Do you have compassion for others? I can't answer that, but you have to answer that. So I brought Reagan on to actually, Reagan Rosenberger, to help us create a shadowing program at Parkland Hospital in the ER, because there were all kinds of pre-med students all around Dallas, UTD, UNT, and so forth, excuse me, who wanted to have shadowing opportunities. So I brought Reagan on as a research assistant, and also in part to schedule folks in the ER. Well, COVID shut it down in March, exactly a year ago. And so we said, well, why don't we do it virtually? So we went out and bought the website domain virtualshadowing.com. And we brought on 6 other kids from UNT, UTD, Texas A&M, and Texas Tech. And we created this group. And we have sessions every Tuesday night at 7 o'clock. We had one last night. Our attendance has been marvelous. Last night we had 800 people online. We have Zoom for 1,000. Plus we stream live to YouTube live online. We've had as many as 1,600 people online at once. And we clearly tapped into a need. We haven't marketed it at all. We put out the word through Instagram and Facebook and Snapchat and some others. We put out the words through UNT, UTD, and so forth. And now, as of this morning, we have reached over 46,000 people who've signed up on our website. We didn't market it at all. It's free. We've reached over 950 universities worldwide in 28 nations. And we had our 39th session last night. Last night, we had a PA who was a physician assistant, who is a critical care PA, and she was just wonderful. She talked about COVID, other heart attacks and so forth, desperately sick people that she takes care of. She also then, toward the end of her talk, spoke about physicians and PAs and finance, which was very interesting. So go look at the website. We've seen different participations over time. And so just to point this out, you can see that we sort of had a spike of people attending up to 1,600 last year, and we had around 800 last night or so. So I don't know if the interest is waning. Shadowing opportunities may be opening back up. We're trying to decide if we're going to continue it after June. We're going to continue virtual shadowing online through June. And then after that, we're going to try to decide if we're going to shut it down. We'll leave the lectures up and so on. We will have by then about 60 lectures online, representing about 120 hours of shadowing, virtual shadowing. So I know at the medical school, we typically like to see students have at least 50 hours of shadowing or more. So we will put ample hours of virtual shadowing out there to at least get some shadowing experience. And we have now, in terms of total participation, we end up having total about 5,000 people watch our talks per week. We've had essentially 40 talks, 39. And so we've had essentially 200,000 participations in our lectures in 9 months. That's incredible. I mean, it just speaks to a huge need. But ladies and gentlemen, it also speaks to the fact that the competition to get in med school, PA school, NP school is enormous. You can't be an average student today and get in school. The competition is enormous. And I said the medical school applications across the country were up about 33% overall this past year. Now I'm going to change tracks. This is coming for the next 10 minutes. I'm going to barrel through this and then we'll take some questions. So I'm going to give you some medical tips. This is Fowler's 15 Laws of Safe Medicine. Sneha, you can give them my slides to give for them to have. This is based upon a lifetime in medicine, 15 ways to not screw up being around a patient. Number 1, always explain a tachycardia. If a patient has a fast heart rate, something is wrong with them. What does that mean? You have to look at the patient. You go, well, I will obviously look at the patient. Don't assume it's obvious. You have to have a meticulous, careful way of the way you examine people. And if the vital signs, like the rate of the pulse, is abnormal, something is wrong with the patient. Now, well, Pappy said this, it isn't what it isn't. It's what it might be that will get you in trouble. It isn't what you've ruled out. It's what you haven't ruled out that may get you in trouble and hurt your patient. So be very careful. You have to complete a differential diagnosis on every patient. You do a history, you do a physical, you do testing, you come back together, and then you put all the information together, and then you say, okay, I'm going to rank order this that based upon my history, the physical, the labs, and my experience, I think it's this. It could be this. I don't think it's this, and I know it's not that. This is called a differential diagnosis. We stink in medicine today, by and large, of creating a differential diagnosis. I challenge you, remember this line, I challenge you, if you go into medicine to make yourself in the future create a differential diagnosis with a great work ethic, using your applied science with a compassionate approach, and you will be a great physician, especially if you continue to study on top of that as well. We're not heroes. We don't have to prove that the patient will do well. Well, he'll probably be okay, send him home. What if he doesn't do okay? Don't send somebody home that's going to go get sicker. If it's blue, it's broken. The guy twisted its ankle and now it's swollen and it's blue. Folks, that's broken. Don't just give him a pair of crutches. Get the x-ray and be careful. I know that seems silly. Invite me back and I'll give you examples of things in which you see a blue swollen ankle, but in fact, it's actually really broken. I saw one of those last week. Never send home a sleepy baby that doesn't come to full wakefulness. You have a kid come in, the parents bring him in because he's been fussy and feverish. You're about to discharge him, wake the kid up, put him on the floor, make him scream and cry, and see that the kid comes to full wakefulness, and then you can send him home. And the corollary is that if the baby vomits his first dose of medicine that you give him, be careful unless you've seen the lumbar puncture results, because this kid may have meningitis. Once the patient is out the door, you've lost control of the situation. It's so easy in medicine to say, well, he'll probably be all right. Once you send him out the door, you've lost control. And you have no ability then to control that patient's outcome any longer. I'm very careful. I am an old man in medicine. And if I'm going to give a script to a patient for a disease, I give them the first dose of medication almost always in the emergency department. I want to make sure that they at least get the first dose of medicine. Somebody asked me recently if there were two things I could fix about Parkland Hospital, which is a giant, it's the busiest emergency department in the United States. It is a giant inner city urban trauma center that takes care. We see over 300,000 patients a year. On campus, we actually see, together with Clemens and Children's ER, over 500,000 visits a year. Somebody said, how would you fix your hospital? I'd say I would have a guaranteed appointment for them to go to after they leave the ER, not if they have the money and can get insurance, guaranteed appointment. And I would be able to hand them their prescriptions to make absolutely sure they could get their prescriptions. This is why I'm such a fan of the Affordable Care Act. You're entitled to your own politics, but at least giving people the possibility of being able to get care and to be able to get appointments and get prescriptions is the right thing to do. It is the moral imperative in this nation. You're entitled to your own politics, but I'm telling you that if we're going to take care of people, we have to take care of people, because we have to be a fierce advocate for the needs of our patients. We are there for them. They're not coming to see us and saying, hey, Dr. Fowler, I just came to check in today. I'm here in the ER. I just thought I'd see how you're doing. No, they're coming in because they have an issue. And I use the applied science with the work ethic and the compassion to deal with them. Advocacy, to speak up for your patient, is critical all of your career. You have to find out what the real emergency is. The guy comes in and he says, for example, that he's having just terrible, horrible exacerbation of his back pain. And you go, oh God, and he's writhing around. You go, gosh, I'm so sorry. And so you go to his medical record and you see that he's been in the ER every 3 days for back pain, has been getting a narcotic shot every 3 days. And then you go to the prescription database and you see that he's been getting 120 hydrocodone narcotic tablets per month. That's 4 per day for years. So what is this guy's real problem? Is it his back pain, or is it the fact that he is habituated on narcotics, and in fact he's in narcotics withdrawal or whatever? So that is one example, but it's to find out what the real problem is. Why does the lady seem so depressed? Is it actually because her husband has been abusing her, as one example? We have two responsibilities in the ER. Is there an emergency present? And if there is an emergency present, we call it ABC, and actually it's XABC, external bleeding, airway obstruction, the patient who has stopped breathing, the B, and the patient who has circulatory abnormalities like pulselessness, like you see in cardiac arrest. That would be a life-threatening emergency. And What is the best diagnosis that you can make? Remember what I said. Well, I didn't give you the one-liner. Folks, you want to be a specialist in your field. I mentioned the differential diagnosis a moment ago, where you do the history, you do the physical, you do the testing, and then you rank order the things and you decide what you think is the most likely thing. You want to be a specialist in your field, whether it's surgery, ophthalmology, ENT, you name it. The difference between a specialist and a generalist, an average physician, is the rigor of the application of a differential diagnosis. An average doc can say, well, maybe this, maybe that, I don't know, it could be this, could be that. But a specialist will do a rigorous application of a differential diagnosis. Artificial intelligence, which I choose to call assisted intelligence, AI is assisted intelligence, is coming, and it's coming in a tidal wave. It will be built into medical records. I fear that our differential diagnosis skills may slip over time if the computer is doing the thinking for us. It's possible that that may happen. What I don't think the computer is ever going to get very, very good at doing is doing the history on the patient. For example, good morning, sir. What seems to be the problem? Oh man, it's like, I got this, could you speak more clearly, please? That ain't gonna happen. So I don't know that computers are ever going to make their way totally into the room, but I think that there's certainly the assisted intelligence of decision-making is going to be there. This is a gift to you down the road. When you're in doubt, if your differential diagnosis is in doubt, go back and talk to the patient. Take more history from the patient. This is a critical point, ladies and gentlemen. Develop a physical exam that you trust and always do it. I cannot tell you the hundreds of times that the students and residents who've examined a patient come to me and they've left out steps on the physical exam. For example, the patient seems to be in congestive heart failure and they haven't looked to see if the patient had neck vein distension, as an example. There are many, many more examples of that. So develop a physical exam that you trust and always do it. What's the most common cause of tachycardia that we see? Well, it's probably drugs of some sort. What's the most common cause of bradycardia, slow pulse rate, that I see? It's probably not marathon conditioning in my ER. It is probably people that are on drugs that slow the heart rate down, like beta blockers. A normal electrocardiogram rules out nothing. I would love to come back to you and give you a talk, Sneha, if you'd like for me to, on basics of electrocardiography. As my friend Alma Matu says, the ECG, the EKG is your best test. And finally, altered mental status always means that something is wrong until you prove otherwise. And the corollary, is it dementia or is it delirium? Okay, so that was a gift for you. I know we ran through that very quickly. You can have the slides, take a look at them. I would encourage you to reflect on that as you get into medicine. Develop a physical exam that you trust. Look at the damn vital signs. If the pulse rate is rapid, tachycardia, don't send the patient home unless you've explained it. Well, he's on an albuterol inhaler. Well, fine, you've explained it. But anxiety alone doesn't explain it, for example. Well, that was a whole lot. So you are welcome to email me. I am ray.fowler at utsouthwestern.edu. If a lot of you email me, I'll get to them when I get to them, but I'd be happy to chat with you. Medicine, ladies and gentlemen, is the art of compassion. It is a test of the inner will to offer your support, your heart, parts of your life, of your time of your life in the care of another, to help ameliorate their suffering and to deal with their disease. Don't get into this field if you fail the internal test of the art of compassion. The virtual shadowing is on the internet. You're welcome to check it out. We have 39 lectures out there and available now. They're all on YouTube and they're streaming. And just go check them out. I give a similar lecture to this on the very first lecture, which is, why in the world are you crazy? You want to get into medicine? The lecture number 2 is about the admissions process, about what you actually have to go through to go to medical school and PA school. And then the third talk is about the history and the physical examination. and you can take it from there. So anyway, I'll now, Sneha, take questions or comments, and I hope I didn't go too long.
Are there any last minute questions any of y'all have? Or
I put you all to sleep.
I have a question if you don't mind me asking.
Of course.
So there are cases where like a patient won't fully discuss their medical history in honesty and truth. What would you do in that case then?
Let's take that. That's a great question, Kylie. Let's take that in two flavors. Kylie, how may I ask? I don't mean to be rude. How old are you? Do you mind? I'm 68. How old are you? Or do you mind saying? Let's say you're 18, okay, or 20. I don't know. All right, whatever. You're on. That's fine. Let's say you're 20. Do you remember what happened when you got sick when you were 8 years old, 12 years ago? Do you remember what happened?
No.
Yeah, of course not. I don't remember hardly what happened last year. Think back. What do you remember from the age of 4? Do you remember much from the age of 4? Human memory is so fallible, and people will come in, and frankly, they often don't remember what they had or when they had it. You ever had hypertension? No. Well, in fact, they were on meds years ago, but they forgot, or they put it out of their minds, or they think they took pills for a while and they got well. And then there's the flip side of that, which is to say, when people won't be honest. Well, I gave you the example of the guy with a backache who came in, and what he seems to be really there for is pain pills, because he's developed a pain pill habit. Or the lack of honesty might be because, in fact, the woman is depressed because she's being physically and mentally abused by her husband. And the reason she can't sleep at night is that she is so unhappy and she's so miserable. She has no job. She has 4 kids. She doesn't want to be thrown out on her own, and she's terrified, but she comes in because she's depressed. But she doesn't want to get her husband in trouble because he's the sole breadwinner for the family. And what she wants is a pill that'll make it go away. When you see, I'll conclude that point by saying that when you see patients, you're going to see the breadth of humanity, all things, all conditions. This is why many physicians specialize. They only do surgery or ophthalmology or ENT and so forth. So they concentrate in a certain area, as opposed to my field, emergency medicine or family medicine, where we see everything, every organ system, every disease and so forth. And so part of it, frankly, is that they don't remember. Another is that they may have things to hide. And those things to hide may be things that they don't want to talk about for personal reasons, or in fact, it's a substance abuse problem. Long-winded answer. I hope that helped.
Thank you.
Let's do 1 or 2 more. We got 5 more minutes, I think.
Dr. Fowler, there's a couple of questions in the chat. Would you like me to read them out for you?
Absolutely.
Okay. The first one is, does volunteering in third world countries help for medical school?
Yeah. Yes, definitely. Things good for med school. Medical assistant stuff is good. Going abroad and doing stuff medically is great. Mission trips, that certainly is helpful. Listen to this. No single one thing is going to get you in med school. I gave you that list of all the things: the shadowing, the community service, the teamwork, the interviews, the letters and so forth. You have to do them all. But yes is the answer to the question. Going abroad and doing medical work is a great idea.
And are EMS medical directors still mostly non-fellowship trained?
Are EMS medical directors, you got an EMS person out there? Most EMS medical directors are not fellowship trained. Now, having said that, EMS medicine and the people that are board certified in it is now the largest subspecialty in emergency medicine, because there's so many of us. We're larger than toxicology and so forth. And so now, having said that, there was a thing called grandfathering when the first EMS specialty exam was given, allowing the docs like me who'd been working in EMS for 5 years or more. I'd been out for 35 years. to be able to sit for the initial exam, and that's called grandfathering. And so there are thousands of grandfathered EMS physicians. They're board certified, but many are not fellowship trained. Good question.
I think there's like a few more, but this can be our last one.
Okay.
Dr. Fowler, when you mentioned about having any doubts during a diagnosis, have you ever experienced any doubt when diagnosing a patient? How did you go about that? And have you ever had a case where the patient was right and you may have been wrong?
Sneha, I couldn't understand you. You were so close to the mic. I just couldn't understand you. Could you try it again?
Yes. Yeah. When you mentioned about having any doubts about having during a diagnosis, have you ever experienced a doubt diagnosing a patient? How did you go about it? And have you ever had a case where the patient was right and you may have been wrong?
Absolutely. That's a great question. And I'm sorry I asked you to repeat it. I am so humble about the number of times I've been wrong in medicine. And the thing in emergency medicine, if I'm wrong, I may be dead wrong because, that shortness of breath that I really don't think is anything, in fact, could be a heart attack. And so it is so important to be humble about what you know and what you don't know. That gets into that one-liner I gave you a moment ago in the rules that says it isn't what it isn't, it's what it might be. And this is why the creation of a differential diagnosis is so important. And yes, absolutely. I've had many times over the years where a patient said they thought it was something. And I said, nah, that's not what that is. And then I worked the patient up and I would go in and I said, I agree with you. And the important thing is to not take yourself too seriously. Do a great history, do a great physical, complete your differential diagnosis and give it your best shot, but don't take yourself too seriously. Don't pay too much attention to the first person singular pronoun, I this and I this and I this, because you need to get off your high horse and be a human. And by the way, when you write your essays, please, for goodness sake, get somebody to proofread them so that you use good grammar. Don't begin every sentence with I did this and I did this and I did this. That is crappy grammar. Don't do that. Write it as a narrative, as if you were writing a book or writing a nice short story. Make it where it would be fun, a fun story to read. Well, all right. What fun. Thank you for inviting me.
Thank you so much for speaking with us, Dr. Fowler, and thank you all so much for coming to our session. I hope you all enjoyed it. In order to receive credit for this session, you must complete the quiz and achieve at least a 60%. Our quiz is on our website at thepremedscene.com. And if you have any more questions, you can reach out to Dr. Fowler. I know he gave us his email. We will send that out in the PowerPoint later.
All right, folks. Have a great night. Thanks for having me.
Thank you.
Bye now. Good night.